7. And the legacy effect is, if the patient is younger, they are going to have long-term cardiovascular, macro and microvascular and other complications much more often. Suppose if somebody is, let us say, 75 years or 80 years, even if the A1C is something like 8%, is still acceptable. So for your patient, I would think about A1C of about 7, uh, somewhere between 6.5 to 7 also is okay. That is one. And my, I think add-on drugs will be, I agree that you need to reduce his weight, but the problem here is we don't exactly know what his weight was, what his BMI, was, I mean, we are only just imagining. So keeping that aside, moreover, as you have pointed out, it is going to take a longer time to reduce it, and it is in his own hands. So whatever is in the patient's hands, works rarely, because many of these people of this category, they hardly ever follow the, lifestyle modifications that easily. So personally, I had never been dependent on the lifestyle modifications. The only one thing which I always insist is only a stopping smoking. Rest of everything, diet, physical activity, we do advise them broadly, but my own impression is they really don't follow that as religiously as you would like them to be. Keeping that problem aside, the second drug could be gliptin, as Pranit was suggesting, that's fine. Or it could also be SGLT2 inhibitor, because his ejection fraction is low and he is a diabetic, and SGLT2 inhibitor can drop the A1C approximately to 0.5 to 0.8%, which means that it is likely to take us down to the target A1C. Provided, I have a few ifs here. One is that they should not be having any recurrent urinary tract infections or any urinary tract pathology. That is important, because otherwise these people with SGLT2 inhibitors end up with recurrent urinary tract infections, pyelonephritis, chronic pyelonephritis, renal failure, add-on diabetic kidney disease, renal failure. The second thing will be, because he is a diabetic, I would like to be more sure about his peripheral vascular condition. If he does have a preceding or previously existing, even if asymptomatic, peripheral arterial disease, then they are prone to leg ischemia and then gangrene and likely amputations with some of these drugs. So lack of symptoms, just physical examination of the pulse alone may not be enough. Some of them might require at least ankle brachial index. That is another thing which I would like to look at. If that is normal, I have no problems with SGLT2 inhibitors. Third thing, there is a paper which was published very recently, maybe 2 weeks back, from Canada. It is very interesting. Those who are on rosuvastatin and canagliflozin, they are developing. They have 3 patients, if I remember right. They developed extensive rhabdomyolysis and then ended up with myocardial dysfunction, acute kidney injury, elevated muscle enzymes, etc., etc. Now they hypothesized that canagliflozin will increase the absorption of the rosuvastatin and then decrease the metabolism of rosuvastatin and also decrease the renal excretion, which basically means it is going to build up the body level of the rosuvastatin to the toxicity levels. That is how those 3 patients reported from Canada are said to have developed the extensive rhabdomyolysis and then following cardiac and renal complications. So that is another thing which I would keep in mind. But ultimately, many of these drugs, at the moment, if you want to use any drug in a patient like yours, obviously it has to be benefiting cardiovascular profile. That is the, I think, benchmark. You can't use any anti-diabetic drug, but that drug friendly to a diabetic patient, so much so that it has to be either cardiovascular neutral. Most of them, many of them are cardiovascular neutral. It neither betters nor worsens, but some of them are actually, they are cardiovascular friendly, like for example SGLT2 inhibitor and Metformin, etc. So that is another new information which I have gathered in the last 2 or 3 weeks. So that is something which I would like to highlight.
Perfect. Thank you so much, sir. Dr. Prithvi, I'll get back to you just in a second. I'll just unpack a few things that Dr. Krishnan Raju said. So I just calculated BMI of this patient is 28 for further discussion, anybody who has. The reason why, sir, I brought up this ticagrelor and Vimada along with it is because, you know, like in a practical scenario, this patient, 48-year-old male, whom you saw for the first time in the hospital, after that, this is third time you are seeing. He's already on drugs which are costing him 200 rupees per day. And of course, in an ideal situation where money is not an issue, you would do everything. So that is particularly the reason why I brought up these two medications, ticagrelor and Vimada, in terms of how much rapport you establish, how early you want to challenge a patient with a costly therapy, knowing that the therapy is a better drug. I would also invite suggestions from the audience in terms of who all does screening ABI before starting SGLT2, because as we know, there were some early signals of SGLT2 leading to increased amputation. Again, mostly data with CANA, but the recent data, particularly with APA and EMPA, like Emperor trial and all this, none of these showed that signal. So whether it was an early selection of patient or whether it's a drug effect, that question is still unanswered, but certainly that is one of the concerns. UTI is an obvious concern. And I do want to highlight that canagliflozin and rosuvastatin are bad combinations together, because in that trial, sir, if I remember, patients were on high doses of rosuvastatin. We're talking about 20-40 milligrams daily. So certainly, if your patient is on canagliflozin and 40 milligrams of rosuvastatin, there is something to be concerned about. For 20, I'm not quite sure. For 10, probably going to be okay. But there is some signal about it, and that signal is not there with other SGLTs, but certainly with cana it is there. Dr. Prithvi, you had something to add. I'm unmuting you, so please go ahead with your thought.
So, hi sir, good evening everyone. So regarding this target itself, sir, so I also agree with Sir Krishnan Raju, sir, that it should be around 6.5 to 7. So, and sir, before for Praneeth sir, I'm asking, so before going the vildagliptin 50 mg BD, so can we add any other drug, third drug? Yes, sir.
Can you be more specific, Dr. Prithvi, what drug exactly you want to add?
So SGLT2 inhibitors in the low dose, that is 12.5 mg, if it will be better.
Yeah, so to answer two questions, one about the targets of HbA1c of a strict target of 7 and all. This somehow stuck to me from the days of medicine when I read about these ECHO trials and all, where when the targets are kept very low to the level of 7 or low, patients were having high risk of hypoglycemia, and those patients who were having hypoglycemia had increased mortality. Somehow this stuck to me, and this is something which I really fear when I manage diabetes. So in that way, if I have to say, I'm a bit conservative in that way, where I really fear hypoglycemia. That is where my targets are not too rigid. Yes, I agree that for a younger patient, the lower targets need to be made, but this is my personal take on the HbA1c targets. to be precise. And Anoop was saying, the most important thing which I also want to ensure is the compliance. I don't want my patients to stop the drugs just because of the cost of it. The earlier compliance rates are better post an incident, first 3 to 6 months, and then on the frequency of visits increases and the compliance of drugs is reduced, and the patients, again, my thought process, patients tend to rationalize things like you want to stop the list of 6 medicines, which one to stop, and they tend to stop the costliest medicines, which unfortunately will be the most important in the list. So that is where, to ensure the compliance and safety, I preferred using this gliptins, and probably once I get the confidence that the compliance is ensured, I would be switching over to the SGLT2 inhibitors.
Thank you, sir.
Yeah.
So one of the very critical point, I think, because remember, this patient has 2 stents in the LAD, and you really do not want this guy to get this impression that SGLT2 is his main drug, and for his weird thought, you don't want him to stop his ticagrelor. I mean, these are kind of things which can get really in trouble. And of course, an ideal situation, they don't need to worry about money, and then you can spend half an hour with this patient trying to convince them and all those things. Anybody else has any running thought? Dr. Krishnam Raju, his hand is up. Sir, any running thoughts that's going on?
One missing information is you did not tell us about LV function.
45% anterior hypo, 45% on discharge. We have not repeated an echo.
Yeah, there is an issue there, because immediately after the infarct, ejection fractions tend to be on the lower side, particularly anterior wall MI. And then there will be stunned myocardium, as you know, or a hibernating myocardium. Once you have taken the, revascularized the patient, either surgery or stenting or whatever, then over a period of approximately 4 to 8 weeks or 6 to 8 weeks, the remodeling will be complete, and then their ejection fraction may in fact be more than, let us say, something like 55 plus. If that is so, if the cost is the issue, you can step down on your Vimada, that is one option. And then if you have already had a patient with these stents done, say, longer than 3 months, you also have the option of changing over to a cheaper drug than ticagrelor, because there are many studies when in comparison, say first month, immediately after this stenting, ticagrelor has a better profile. Up to 3 months, it is still okay. But after 3 months, I don't think there is any strong evidence I know of where it is any better than a combination of an aspirin with prasugrel or clopidogrel or so. That is one comment which I would like to make. Second is a question. Did you check his ejection fraction post-discharge during his first outpatient visit or second outpatient visit or later?
So, sir, I typically do echoes on 6 weeks of MI, and his echo was done at 6 weeks of MI, and that ejection fraction was more or less unchanged. I have not repeated after that. I typically do discharge echo, 6 weeks echo, and then 6 months echo. So he has not finished 6 weeks.
Now here another question leads to another question. The EF will depend on who has done it and what technique. So I will leave it at that.
Yes, sir. He was on my hand, so God bless him.
Yeah.
But that is the best he got,
yeah,
unfortunately.
Yeah. So I think we need to be very careful, because unfortunately most of the labs now are run by less than good echocardiologists.
Yes.
And they think that echo means only ejection fraction and nothing else.
Yes. Yeah, that's an excellent. Sorry.
Yeah, 45% ejection fraction for example, a large sized LV is very severe LV dysfunction. But ejection fraction of 45% for a normal sized LV or a smaller sized LV need not necessarily be that severe, may not warrant a Vimeda, which is also very expensive. These are only comments, I'm not questioning.
Correct. Not at all. That is what we want, sir. We exactly want the comment. Perfect.
So the third comment which I would like to make and close is, even presuming that his ejection fraction is 55 plus or 50 plus, which is now categorized as a sub type of heart failure, what they are now calling it as a HF corrected EF. You know, HF-REF, HF preserved EF, HF normal EF. This is used as a corrected EF. So some important information has come in the last few months that these are the people who are not normal still. Though ejection fraction, the number looks okay, but these are the people who require lifelong management, and these are the people who are likely to go into recurrent heart failures, recurrent hospitalizations, and then when they have a recurrent symptom or recurrent problem, then ejection fraction might again drop from 50 plus to again 40 or less than 40. Once you correct it, it might again go up above the 50. So this is a new category of heart failure, which has been studied in multiple centers for the last 2 to 3 years or so. The recommendation is that even if the ejection fraction is corrected, but they should be treated as if they are potential heart failure patients. That is my last comment.
Perfect. Thank you so much. Ma'am, I'm inviting Chandramukhi madam to give her thought, and then I will introduce my very special guest for today. Chandramukhi ma'am, I have a specific question also regarding the case, but as a general. So we heard at least 3 cardiologists talk about what they would do. Where are all those glycomet GP1, GP2, GP3s? I mean, all the patients are on those. Is it that we are prescribing more sulfonylurea than what we are willing to talk about? And how would you approach this patient? Madam.
Hello.
Yes, ma'am. You heard my question, right?
Actually, I got one emergency call, so I could not hear to the first part of the question.
Okay. You're able to hear me now?
Yeah, I'm able to hear.
Okay. So you heard the case, right, that we are discussing?
Yeah.
With TRMI. Okay. So my question to you, number 1, is that how would you manage this patient? And question 2 is, we heard from 3 cardiologists, and you being one of them, you being one of our cardiologists as well. All the patients we see, they are on all these glycomet GP1, GP2, GP3. So there is so much sulfonylurea in the market that we, for some reason, are willing to prescribe but not willing to talk about. What do you see in these kind of patients? Do you think these patients will be prescribed sulfonylurea more frequently, but will be talked about DPP-4 or SGLT on the meetings? I mean, is there a discrepancy? How would you approach this patient, and how would you answer my skepticism?
Yeah, so first question, many of the patients are being prescribed with GP1, GP2, which is a combination of glimepiride and metformin. So because glimepiride is very widely available and easily available, and it is cost-wise also it is a little bit less costlier than the other drugs. So many of the patients, they will be on these combinations, but especially when the patient population in our practice we come across, so these patients will be having cardiovascular morbidities. So in such patients, DPP-4 inhibitors or SGLT2 inhibitors will be better choice than the sulfonylureas. So considering this case which we have discussed, so I agree with Praneeth that first we have already started metformin and we have achieved the maximum dose which we can give, that is 2 grams. Then he requires additional therapy, and because he is having some degree of LV dysfunction and already he had a MI, so either DPP-4 inhibitor or SGLT2 inhibitor will be the second choice. And now Krishnan Raju sir has raised a question regarding the peripheral vascular disease in patients who are receiving rosuvastatin and SGLT2 inhibitors. So I think we should have a we should be cautious when we are starting SGLT2 inhibitors in these patients.
Perfect. Thank you so much, ma'am. I will introduce my guest to you guys. He is Dr. Rakesh Sahay. I'm sure all of you know, he doesn't need any introduction. I will still try to introduce him. He is Professor of Endocrinology at Osmania University. He's here on my request. Thank you, sir, for joining us. You heard all these cardiologists talking about diabetes treatment. I'm sure we have no idea what we are doing. So you heard the clinical case. If this patient came to you, how would you approach it? And if you could answer some of the questions that were discussed in front of you. To you, Dr. Sahay.
Yeah, thank you, Dr. Anoop, and good evening to everybody. I think that was an interesting case which presented for the first time with diabetes, and although from the HbA1c, we know that his diabetes has been there for a couple of months, if not more, and he has, but nevertheless he was unaware of his diabetes, and he presented for the first time. And when he presented his to the ICU, I mean with the acute coronary syndrome, I think his blood glucose levels were significantly high, as you had mentioned, somewhere in the range of more than 300. So in that situation, I would certainly like to use insulin initially, and maybe a couple of weeks I would like to continue insulin also along with metformin, and then I would like to look at the other options. The SGLT2 inhibitors are a very good option, but certainly not in the acute phase. In the subsequent phase post discharge, yes, they would be a very good option in this scenario with the current evidence available with almost with definitely with the empagliflozin and with Cana also, and with DAPA also we have the evidence in terms of the benefit in heart failure. Now coming to the gliptins, in this particular patient, I would not be very inclined to use gliptins because at least with saxagliptin we have a report of increasing hospitalization for heart failure, and because of that, there's in fact a black box warning on all the gliptins. The FDA has given a black box warning for all the gliptins for their use in heart failure. So to sort of look at their use in heart failure. So I would not be very keen on using any of the gliptins. The benefit of the gliptins is that they have a very low risk of hypoglycemia in this particular patient, and the other benefit is probably in terms of the weight. Weight means they're weight neutral. They don't cause weight loss. Now this patient is clearly he has a BMI of 28. He's obese, and he has cardiovascular disease. And in this scenario, the agents of choice would be apart from metformin, after metformin. Coming to the target first, before we go on to a little more details about the medications, I would like to agree with what Dr. Krishnan Raju sir has said, that about the target, we would certainly like to keep it less than 7 and not 7.5, because this is a young person. I mean, but for his ACS which he's had now, he doesn't have a long history of diabetes. He doesn't have generally people with autonomic neuropathy and other causes of hypoglycemia unawareness. Those are situations where we are worried about hypoglycememia. In this patient, I don't see any significant risk of hypoglycemia happening with the medication that he's using. So we are looking at 7 would be a good target for him. If he had not developed the MI, and if he had presented with diabetes earlier, we would have even looked at 6.5 as a target for him rather than 7 also. But now with the MI that he developed, I think we would look at 7 as a good target for him to sort of give him a good legacy for future prevention of other complications that he may develop, and for future recurrence of cardiovascular events. Now coming to the discussion about SUs. Now let us bring in SUs also. SUs, as you said, if you look at the recent data from the Carolina study, we have seen the comparison between glimepiride and and linagliptin. And we have seen that glimepiride fared as good as linagliptin in terms of cardiovascular events and cardiovascular the MACE, 3-point MACE in terms of that. So that although it did cause a little more hypoglycemia, but hypoglycemia that happened with glimepiride did not kill the people. And the other issue was that there was probably the dose of glimepiride was actually increased from 1 to 4 milligrams very rapidly, which we don't do generally in clinical practice. So I think from all in all, that trial gave us a little assurance about the sulfonylureas in terms that they do not cause so much hypoglycemia. The hypoglycemia that happens is probably not going to cause going to increase cardiovascular events to that extent. But in that trial, at least it didn't do that. So yes, we do. I mean, we see a lot of prescriptions of glimepiride going around. I mean, and glimepiride is used very often. In patients who are at risk of hypoglycemia, we need to restrict the use of glimepiride and probably look at using the drugs which cause less of hypoglycemia, like the DPP-4 inhibitors or SGLT2 inhibitors. Coming to the point regarding SGLT2 inhibitors, the earlier data from the CANVAS trial showed the increased risk of amputations with CANA, and but the subsequent CREDENCE trial did show that amputation don't increase. So that issue is not very, I mean, in the sense, is not a major issue in terms of starting canagliflozin, as Dr. Krishnamraju had again highlighted about the recent interaction which was reported regarding with the canagliflozin and rosuvastatin. That is a very important issue that we have to keep in mind, because this patient also, I'm sure, would be on a high dose of the statin, of rosuvastatin particularly here. And so I would look at starting, if I would start a SGLT2 inhibitor, I would prefer empagliflozin, and the dose is generally 10 milligrams also. The 12.5 is not a standard dose that is recommended, but that's a adaptation which many of us are using, because we get these tablets of 25 and 10 at the same price. So we try to optimize the cost by using half of the 25 to cut down the cost. But yeah, so that we are giving more than the 10 milligrams that we are looking at. So those are some of the points I would like to make. And
Sir, I have a follow-up question on your comment, and then if anybody else has any questions to Dr. Sahay, this is your chance, because I don't know when you will get the next chance to ask him. Sir, my question to you is, walk us through your insulin thought in this patient. In the hospital, acute MI, sugars were in 300s. Why insulin?
yeah, in that scenario, a short-acting insulin, and if the and also maybe a basal insulin, a small dose of basal insulin, and so a basal bolus therapy during that period would be what we would look at.
And what would you consider that period? Because typically inpatient, we are giving insulin anyway. Inpatient, we are not giving tablets. But
Yeah,
you suggest
right.
that early on as well, in post-discharge phase, we should give insulin, or we can give tablets at the time of discharge in this particular case?
Yeah, I think many of these patients can be transitioned to just continuing the basal insulin for maybe a couple of weeks more, maybe 6 to 8 weeks, or maybe 12 weeks. We continue the basal insulin by along with the oral medications, and then probably can be off that. And that's people who have a new onset of diabetes. They tend to be good to even stop the insulin after a couple of weeks of using that. But those who have been having long durational diabetes, they obviously would need to continue insulin to maintain their glycemic control.
And what is the thought process of giving insulin for the first 6 to 12 weeks? Even if let's say towards the end, if the sugars are reasonable at the time of discharge, would you still advocate early on insulin?
Yeah, going by that concept of a good legacy effect, and the fact that early insulin therapy, I mean, all the trials which have looked at early insulin therapy have shown a good long-term, sort of a good, reasonably good sort of period of low requirement of medications after using initial insulin therapy. So based on that data, we would prefer to use the insulin for at least 8 to 12 weeks initially.
Perfect. Thank you so much. I'm sure a lot of our audience has got questions, so I'm going to keep you unmuted, sir. And I will first, Praneeth, any thoughts you have? Your hand is up, and then I will open it to other people.
No, the following question of the earlier discussion, the question that I have is regarding the insulin. My understanding about insulin and the other drugs is the other drugs or the oral drugs, we depend on the beta cells which we have in pancreas, and essentially we are asking those beta cells to secrete insulin. How do we know that? Sometimes I hear endocrinologists saying that the insulin reserves are now gone or the beta cells are depleted, and we do need to give them some form of insulin, and without that your drugs are not going to work. So can you help me understand when is a point that patient will definitely need some insulin versus someone whom we can still try mixing and matching with the other oral hypoglycemic agents?
Okay, so although we have, I mean, we can do something like measuring their C-peptide and all that, but generally we don't rely on that in routine clinical practice. What we would go by is the BMI of the patient and his duration of diabetes, and the response that we're seeing with the oral agents to decide whether he has adequate insulin reserve or not. I mean, somebody who's on insulin and who is having a duration of diabetes, long duration of diabetes, that is a person probably who has low insulin, endogenous insulin secretion, and would require insulin to be continued. So that's how clinically it would be assessed. Although we could do a C-peptide levels and see a level of more than 0.6, generally indicating that there is adequate insulin secretion. Below that, showing that definitely it's low and it requires insulin to be used on a regular basis. I don't know if I've answered your question.
Yeah, got it, sir. Thank you.
Sir, you are unmuted.
In the scenario where we are using it initial period, many times we are using it initially at the onset of diabetes, or in this particular patient when he has not had a long duration. I mean, he has had diabetes for a few weeks or months before onset of before presentation, but he doesn't have a long duration of diabetes. Here, if you're using insulin, we are using it for a short period of time, maybe 8 to 12 weeks, to sort of to get good glycemic control and have a better response to the oral agents. Because there is some data out there to suggest that when you have very high glucose levels at onset of diabetes and you're using oral anti-diabetic medications, as you said, you're depending on the beta cell function at that time. You're probably, particularly when you're using secretagogues like SUs, then you're probably going to cause a little damage to the beta cells, or rather increase the apoptosis of the beta cells. So there's some evidence to say that, although not very robust evidence, but that's on the basis of that we prefer to use insulin.
Shastri sir, your comment, please.
Yeah, just a couple of questions to Dr. Rakesh. Thanks for joining. I'm sure you'll be uncomfortable with using metformin during the acute MI phase, and all this discussion is at the time of discharge. Now, based on the insulin requirements to control the blood sugars, probably you'll have an idea about the requirement for insulin vis-a-vis not requiring insulin. That is one point. And second point is this legacy effect. I suppose everything has come from the UKPDS trial, and the duration of the intensive versus whatever the standard control of the diabetes there is almost 1 year, and where you bring down the HbA1c levels to less than 7. But do you think that legacy effect from the UKPDS trial is applicable for this particular patient who is presenting with a, agreed it's definitely diabetes, but first time detected diabetes, a HbA1c of 7.5 and reasonable, not very bad sugars on metformin 2 grams per day. Do you think it's really a bad diabetes with without beta cell reserve? And third thing is about the DPP4 inhibitors. If I understand well, please correct me. The warning from the FDA for LV dysfunction is for saxagliptin and elogliptin, and not for other trials. We saw that that such a recurrent heart failure hospitalizations are not there. If I remember well, for the other DPP4 inhibitors, please correct me. And the last question is, why is it that tenelgliptin, which of course doesn't have many studies, but seems to be very effective in day-to-day practice and which is very much cheaper compared to other DPP4 inhibitors, why are we not encouraging it? That's all. Thank you.
Yes, sir. So actually, to very interesting question, sir. The first question which you said was about the use of insulin. As you said, very rightly said, that the dose of insulin also would help us in clinically understanding whether the patient what the patient would require subsequently, whether he should continue insulin or whether we can put him on oral anti-diabetic medications. Regarding the second part which you said about the gliptin, sir, very true that saxagliptin and alogliptin had that problem of increased hospitalization for heart failure. But surprisingly, when the FDA gave the black box warning, they gave it for all the gliptins. Although sitagliptin clearly in the TCOS study has not shown an increase in the risk of hospitalization for heart failure, that was clearly not there. That signal was not there, and that did not happen with linagliptin also in the trial of linagliptin. But still, FDA has given this black box warning for all the gliptins. And the other point that I would like to highlight at this point is that when you look at the Carolina study, although I mean we said that the MACE was not different between the two groups, that is the group on glimepiride and the group of patients who were on linagliptin, and the group which was on linagliptin did better in terms of having lower risk of hypoglycemia, but they had higher risk of hospitalization for heart failure as compared to the group which was on glimepiride. So what I'm saying is, although these are not contradictory, but I mean I would saying that just looking at all the evidence, we would not be very enthusiastic about starting gliptin today in this particular patient.
I want your comment about legacy effect, how much it is applicable compared to the UKPDS, and another not very related. I take the point about DPP4 inhibitors and heart failure, but in general, why are you not promoting tenelgliptin, which is cheaper? Just that answer also.
Yes, sir. Teneligliptin, as we said, that it is much cheaper. It was introduced at a time when other gliptins were very costly, and teneligliptin was very economical. Today, the vildagliptin prices also come down. The problem with teneligliptin, as I mean, you would be able to tell me more about that, about the QT prolongation, which is reported with higher doses of teneligliptin of more than, I mean, in the they said that with a very high dose of 80 milligrams, it is very clearly seen, and with 40, it may sometimes be seen if somebody is taking erroneously little higher dose, then they may have that. With 20, not much of it has been seen, and there are some Indian observational studies which have not noticed much of QT prolongation. So that's the only problem that has been noticed with teneligliptin. But otherwise, efficacy-wise, if you see, it is sometimes better than some of the gliptins. Like we see that with linagliptin, we don't see that much of efficacy, while you have renal safety and other aspects. But teneligliptin sometimes scores over the other gliptins in terms of the efficacy-wise. As you rightly pointed out, that you see a good reduction in blood glucose levels with teneligliptin. But the only concern that most people have is that we don't have a good cardiovascular safety data as is available for sitagliptin or linagliptin. So that's the difference, I would say. And coming to the last point about the legacy effect. Well, in UKPDS, it was a 5-year follow-up, sir, and what was done was not a very good control. Control was not as great as we achieve in most of our patients today. There was a difference. The intensively treated group achieved 7% on the average as compared to 7.9 on the other group. and what they found was that after 10 years of another 10 years of follow-up, that is after the initial 5 years of average follow-up of each of these patients, and they were followed up for another 10 years. That after that 10-year period, these people who were initially intensively controlled actually showed that legacy effect. So in this patient, but for the acute cardiovascular, ACS that he's had, he doesn't probably have any of the microvascular complications. So if you're going to provide him, legacy effect is probably in terms of the other microvascular complications and in terms of probably recurrence of cardiovascular events. And that I think it still holds good because that was clearly shown that that legacy effect, I think, will it works for our patients also, and this patient also stands to benefit because he's relatively young, and maybe over the course of few years of follow-up, we would certainly feel that he's protected from complications if he is maintaining good glycemic control.
Dr. Sahay, I have some quick questions for you, maybe just like a short answers. Tenligliptin and Vilda are not FDA approved. Any idea why?
Vilda, when it was initially applied, they had a problem with increase in liver enzymes noticed with 100 mg of liraglutide given at 100 mg given once a day. So for that reason, they didn't reapply, and then it didn't come up. It's approved by the EMA, and tenligliptin has not gone for any of these approvals. It's a molecule, Japanese molecule, which has not gone for these approvals.
Okay, because the early alerts of heart failure with the DPP-4, I wonder if one of the reasons why they didn't go for the approval was because the lack of robust data, because they probably knew that FDA may not approve right from the get-go. That is just my thought, because DPP-4 never caught up that much in US for probably the same reason amongst the cardiologists. Second question that I have for you is, what is the role of these acarbose and voglibose and all this in the Indian scenario in cardiac patients? Just share your thoughts on that.
Yeah. So if we were to actually extend the discussion today on what are the other options available for this patient if you are not going to give him a SGLT2 inhibitor, or if he happens to have this patient probably doesn't have a UTI, or is a young patient, and he may and he's also obese, and he may be very well suitable for a SGLT2 inhibitor like empagliflozin, maybe the choice that I would look at using. But in case if he had any of these contraindications, and if you're not able to use it, or if he's not able to afford it, then I think a good choice would have been the acarbose would have been a good choice, given the data that we have in terms of at least observational data on cardiovascular safety, and data from the STOP NIDDMS trial, which showed that there was a good cardiovascular benefit with acarbose. I think that would again be a good choice.
And my last question to you, and then I'll have my audience see if they have any other question. What do you think GLP-1 receptor agonists are there in Indian scenario? Again, data is out there, everything is there. What is your thought on it?
Yeah, they are a good group of drugs. Today we have the long-acting GLP-1 analogs, which are like dulaglutide and semaglutide, yet to come into India, but and liraglutide is the one available. So they both have cardiovascular safety data available, and cardiovascular beneficial data, rather we could say that they have both been shown to have cardiovascular benefit, and I would choose them in obese patients along with metformin. That would be a good choice. In this patient also it could be a good choice, but I'm a little concerned about the heart failure, and I would not like to use that as a first agent. Rather prefer the SGLT2 inhibitor because of the heart failure.
And how do you manage cost in these scenarios? Because again, in the consultation room, that is one thing that one cannot avoid when you prescribe GLP-1 agonist.
Yeah, that's the major issue. That's the major issue, and also the initial tolerability of that is a major concern. A small number of patients cannot tolerate it, even cannot tolerate it at all. So while almost all of them have nausea and vomitings in the initial period, but that settles down over a period of a week or 10 days. Some people do not tolerate that at all, and they cannot use it. So those issues are there. The cost is a major issue. And I mean, while SGLT2 inhibitors, probably the cost is much lesser than the GLP-1 analogs if you look at it.
Do you have any tricks, like do you have any, like, setup with the pharmaceuticals that we can also tap on, that we can get in 50% discount or something? Is there a shortcut to get it cheaper?
Well, we get it at a little lesser than the mark price, but I don't think we get that great discounts, and people are not able to afford it. Many people.
So right now, that is the cost, whatever it is, that is there, right?
Yeah.
Okay. All right.
Endocrinologists are not medical oncologists.
Yes, sure, absolutely. Okay. Anybody else has any questions, comments, thoughts about this case, and for Dr. Sahay, who is here with us to answer your question? Anybody would do anything differently with this case, or would have any other insights about this case? This is a routine case for cardiologists where patients come in.
Anoop, I would not rush to start other medicines. I
Okay.
suppose the post-MI, the first visit is about, I think, at 1 month. So it will take more time. Probably the patient is not active after MI. You would have advised bed rest restrictions, and also the fact about the HbA1c will take time to decrease, and he's definitely obese. And people after MI, it's not that they don't follow the lifestyle modifications. I would probably, it's not going to kill him. A little sugar of 130 and 180 is not going to kill him. You just motivate him. See, all these medicines that you start, of course, diabetic medicines, you can come down or increase or decrease. But, the cost factor you said, it should not be made to frighten, and you should be given a good chance. Maybe a couple of months, nothing is going to happen. And wait for the weight to come down to optimal weight. At least you decrease the body mass index by 1 point or decrease the weight by 5 kgs. His glycemic control may be better. I would personally not rush to, if the numbers from what you told me and the visit is first 1 month visit, I would rather wait for a couple of months more with lifestyle modifications and bring down the sugars. Wait for it. I would like to hear Dr. Rakesh Sahay's opinion about my approach.
Yeah, I think lifestyle measures are definitely going to be very helpful at any point of time, and weight reduction is definitely going to make a big difference, as we have recent data from studies like the diabetes reversal studies, which have shown a great benefit of weight loss of 10 to 15 kgs. So if this man also is able to lose even about 4 or 5 kgs in the first 2 months of following that, I think the requirement of medications will be much lesser, the anti-diabetic medications.
We have Dr. Praveen here. Praveen is assistant professor of cardiology at Osmania. Praveen, I'm sure the kind of patients we are seeing and the kind of patients you are seeing in terms of socioeconomic status and in terms of availability and all this, if this patient comes to you, what all options do you have, and what would you choose in this patient?
Sir, if this same patient comes to me, I would think of stopping ticagrelor, and I would be for the control of the sugars, I would be starting a glimepiride and voglibose if still the sugars are not controlled.
And tell us your thought process. Why glimepiride and voglibose when we have all these great SGLT2s and GLPs and everything available? Why going back in time?
Sir, it is because the patient should be compliant, and the other thing is, as Pranit sir has already previously mentioned, in our Indian scenario, the one that is costliest, they will be skipping off that. And only when he lands up in the problem, he comes for the next visit saying that, doctor, we have missed only 2-3 drugs.
Perfect.
So,
thank you. Yeah.
Yes.
Perfect. Thank you for your.
Only glimepiride, sir.
Okay. It certainly, I mean, glimepiride, sulfonylurea at some point were considered to be the enemies, and it seems like we as a cardiologist certainly have developed a little bit more tolerance towards it. primarily also because it is funny that most of the drugs, when they look at cardiovascular safety, either they compare it with placebo or they compare it with sulfonylurea, which to me is kind of, that is the safe game these guys are playing. If the new drug comes, they should probably compare it with the established drugs, which is what which will be the real game. But we are sure that's never going to happen. Anybody else has any questions, comments, thoughts, anything? Dr. Krishnan Raju, I'm going to unmute you for a second. Just give us your closing comments or anything else that you have to add, and then we'll start closing the session.
Thank you, Anoop.
Yes, sir. Please go ahead.
Of comments. One is in our ICCUs, with and my other type ICCU are from the hospital. These people are still on sliding scale, and then they are never really well controlled. I would more than 19%. Sliding scale, it is not done properly. Sugar, it's not. They are have to reduce the dose of previous is they stop the next dose. So next thing will be high. Insulin. Again, so the effect is ultimately at the time of discharge. These are never. That is my personal experience, because the understanding and they comes the answer back. Let's stop it. Don't give next dose. Second is one of the principal investigators for advanced study. You know, advanced study, which was done from Australia, funded from the a multinational study. Initially with the largest number of patients in all the countries. The first one was China, and the period was 7 years. And then we continued it later on for up to, if I remember right, 12 or 13 years. Our results at the end of first leg of 7 years did not show any significant statistical difference, whether the HbA1c was 6.5 or it was 7 or 7.2 or so. When we continued the study, I heard Dr. Rakesh talking about legacy of the UKPDS study, but the advanced study was a difference in the microvascular complications. Also, some of the issues at the end of 12 years. So there is certainly there is some kind of legacy benefit when you use it judiciously in those patients who are young. Young, we mean that somebody who is less than, let us say, 50 or so. Then third thing which I want to say is Dr. Anoop Agrawal learned from Dr. So you should have brought Dr. Brinda onto the discussion. You did not. Is that okay?
So she's in the meeting, she's listening all of this, and I'm going to get a class after this. So she's there. She's very well there.
And
Dr. Sahay, there is a question for you from the audience. The question is, The question is, at what level of creatinine or GFR would you stop metformin?
Yeah, the current recommendation is to stop metformin at the eGFR of 30 and be slow with it if you're between 30 and 45. But below 30, we are going to be careful and we are going to stop metformin below 30. That's the current recommendation. And as Professor Krishnamraju has highlighted that the advanced study was typically, I mean, that brings us to glycoside. We speak a lot of glimepiride, but glycoside is a good molecule about which many times we don't speak about. We don't have too many brands of that available, but there was a good benefit seen with in the advanced study, and the follow-up of the advanced on study showed that there was a improvement in terms of the cardiovascular events. Also, there was some benefit seen at the end of the 12 years, and there was a microvascular benefit only seen initially, but at the end of the 12 years, there was clear microvascular and microvascular composite endpoint was clearly molecule, and there was a very low risk of hypoglycemia in that study, because this was the study which was done in parallel with the Accord study, where we were terrified by the hypoglycemia, and as we heard some of, I mean, Dr. Praneeth and others speaking about the ill effects of hypoglycemia and the danger, I mean, the fear that has been created by the hypoglycemia, which was created in the Accord study, as compared to that advanced was a study where hypoglycemia was much less. So I think we should take some comments from Dr. Vrinda also.
Vrinda, what do you have anything to add or suggest? Please go ahead. You are unmuted.
Hi, everyone. Very interesting discussion, and of course, I loved hearing to everyone. To summarize the case, I think he's a fairly young individual. Like I tend to discuss with my patients new onset of diabetes, that the younger you get diagnosed with diabetes, the longer you have to live with it. So the higher, there is a higher risk of you developing complications. So the tighter we can get to the control, the better it is going for you. It is going to be for you in terms of like development of micro and macrovascular complications. So I do agree. I'll be a little bit stricter with this gentleman. I will initially target an A1C of less than 7, and then of course if he's doing well, I tend to get a little bit greedy. I'll say, why not more if he's doing well with the medication. So I think lower targets would be better if tolerated. When it comes to like choice of medication, I think, as has been already discussed, I think this patient seems like established cardiovascular disease, would benefit from weight loss. For the knowledge that we have now, I think adding a oral medication would be better for compliance sake. So like between SGLT2 and a GLP-1, I will prefer SGLT2. And then, cost is a prohibitive thing for now, but of course, I'm learning on the go. So now I think we do have a combination metformin with the dapagliflozin, which seems to be at like half the price of the regular cost of the medication. So a lot of times I'll switch them to the combination metformin dapagliflozin if I want to choose, a SGLT2 inhibitor, and I'm concerned about the cost. I would otherwise, as Dr. Sahay also mentioned, like 12.5 is not a standard dose of empagliflozin, but sometimes for that cost thing, I will prescribe them 25 milligrams and then cut the tablet in half, starting it like once a day before breakfast. But I think I'll push on, like very early on, I'll push on the targets. I'll tell them why it's important. And then probably like, somewhere like lead towards SGLT2 inhibitors. LVEF, I think, would be one of the guiding factors. So like maybe DPP4 inhibitors would be lower down on my list for that same sake. But in Indian scenarios, of course, I've learned that, sulfonylureas do still hold a very important place. So maybe gliclazide, like as mentioned, that in the advanced trial it did seem to do fairly good in terms of hypoglycemia risk, and can be used in CKD patients as well. So if cost becomes restrictive for me, then I may go ahead and choose a gliclazide based molecule for this gentleman. But just to, I know it's I've stretched out a little bit longer on time, but there is a very interesting trial which I have been waiting for it for the past 7 years, called the GRADE study, which basically started when I was in my fellowship, and my center was one of the part of the trial. So, but it is a comparative, like head-to-head trial amongst sulfonylureas, DPP-4 inhibitors, GLP-1s, and insulin. So I don't think so we have any like head-to-head trials between any of the molecules as to what comes next to metformin. The study started before SGLT2 inhibitors got approved. So I think it would be an interesting study to look forward to in the future. I think it is scheduled for completion like next year or something. So that's it from me.
Perfect. Thank you so much. And we are running short of time, so I shall be closing soon. And before I start asking for closing comments, I would like to tell you about our next huddle, which is going to happen on the 12th of August. That will be a Wednesday around the same time. This huddle is special because here we have two guests. Both are experts in the field of generic and branded drugs. They have done their work. They have heard it all. They have seen it all. Dinesh Thakur is a whistleblower. He is recipient of multiple awards, single-handedly took Ranbaxy down. And he is know-it-all in terms of generic versus branded drug. And he was extensively covered in the recent novel written by Catherine Eban called Bottle of Lies. He will be one of my guests next Wednesday. And my another guest is Dr. Harry Liver. He is a cardiologist at Cleveland Clinic. And he has been very vocal about the drug quality as well. And between the two of them, you would pretty much know every single dirt on what generic versus branded drug does, because I'm sure all of us at some point do think about the quality of drug when we are prescribing those. So if you have ever asked yourself the quality of the drug that you're prescribing, you should listen to those two guys. They will be my guest next week, 7:30. So you can use the same link, the same ID to log in, and we will be very happy to have you there. Having said that, and basically on your screen, I'm sharing that image. So you can look into your WebEx platform right now, and that image will be shared, which is the invitation that I have made for next week. With that, I would like to close. Praneeth, your closing comments on this, and anybody else has any other comments, and we'll close after that. Praneeth.
So it was a good discussion. I heard a lot. My perspective changes that I need not fear more about hypoglycemia and do target patients more aggressively. With the availability of newer molecules, the hypoglycemia risk is less. So hit hard and give them a better lifestyle ahead. Thank you.
Dr. Sahay, your closing comments. How did we do about the session? What are we doing? Anything?
Thanks. I enjoyed being here in the session, and I really got a good cardiologist perspective, and I'm very happy that I could contribute to the discussion. Thank you.
Okay. Anybody else has any other thoughts before we close? If not, please unmute yourself if you have any other thoughts. Else, we are going to close the session for tonight. And I really thank Dr. Sahay and everybody else who participated in this. I would love to see you next week, same time. Have a good night, guys, and thank you again for joining.